Settled.
Neither the El Paso Medical Society, its members, nor PBS El Paso shall be responsible for the views, opinions, or facts expressed by the panelists on this television program. Please consult your doctor.
Brachial plexus injury is an injury to the brachial plexus. What does that mean? I didn't know either, so I looked it up. It's a network of nerves that conducts the signals from the spinal cord to the shoulder, the arms, and the hands. There are Cs5s through Cs8s and T1s, all kinds of good stuff, and we're going to get into that this evening. You may have heard it in layman terms in the past as something called backpack palsy or Rucksack paralysis, which is basically in German, backpack paralysis. We're also going to talk about spinal bifida today and the up-to-date treatments and the options that have really impacted the quality of life for people and patients who have this condition. As you know, this is a live program, so give us a call at 880-881-0013. This evening's program is underwritten by El Paso Children's Hospital. And we also want to thank some new people. We have the Burrell College of Osteopathic Medicine from New Mexico State, and it's really nice for you guys to be here. And with us today, we have Luis Zuniga and also Gina Gilderman. And so they're both third years, so they know their stuff. So by all means, please telephone them, get some questions their way. Again, that number is 881-0013. We also want to thank the El Paso County Medical Society for bringing the show to you each and every month, several times a month often. I'm Catherine Berg, and you are watching the El Paso Physician. Thank you again for joining us. We have two specialties here today, kind of different but kind of the same. Lots of nerve endings and just connectivity that we are going to be talking about. Again, brachial plexus. And with us specifically for that tonight is Dr. Sean Diamond. And he is you specialize in a lot of things, just talking here. This is a specialty because it is brachial plexus month. It's hard to say that. And again, when I got the topic for this evening, I thought, what in the world is that? So I did a lot of research. But you also are a hand surgeon, so you deal with a lot of the complexities of our human beings. So we appreciate you being here very, very much.
Absolutely.
And also I have to say, Dr. Diamond has a very calming voice. Every now and again, I know that you don't see what happens behind the scenes, but things get a little crazy, and he was very calm, giving directions to people, and it's nice to hear that, so I appreciate that. And then we have Dr. Guerimo Latif, who has been in El Paso 22 years, and we're going to talk a little bit more about him in a moment. He is specializing in urology, urologist, and he does specifically specialize in pediatric urology, and every now and again works on people that aren't little. But for the most part, we're going to be talking about, with Dr. Latif, spinal bifida, but again, opening it up to other questions too that have to do to pediatric urology. So now that I've kind of covered what you guys do, at least what I have on my paper, Dr. Diamond, we're going to start with you. If you can describe to the people at home, I know we have a topic that we're sticking to tonight for the most part, but describe everything that you do. I always say to the doctors, what do you do all day, every day? And it's easy for me to say that, but that could cover 2 or 3 hours. But how would you describe your profession?
Yeah, that's a challenge.
It is a challenge, I know.
We have an hour, right?
We have an hour. We can extend it to 3 or 4. People may tune out, but that's okay.
So it's probably easiest to explain how I was trained and what I was inspired by and how I arrived here.
Okay.
So I was trained in plastic and reconstructive surgery. I trained at Harvard and Boston, and then have a specialization in plastic hand microsurgery, which means plastic surgery is this massive specialty. Most people think of it as botched or the Kardashians or aesthetic plastic surgery, Botox, filler, facelift, which is awesome.
But you're not that guy.
I'm that guy sometimes, but many times I actually trend towards all the reconstructive aspects. So plastic surgeons are trained in the specialty of what we call the integuments. So skin, muscle, joints, bones, all those things fall within the realm of plastic surgery. Complex wounds. And in my case, I love hands. They're a very complex organ. People are tied to them in many, many different ways, be it a musician or an athlete. hands are very important for people's function, their livelihoods, and they're very tied to people's psyches. And when people injure their hands, they go through quite a bit of mental problems as well. So being a doctor of hands, you're really a doctor of skin, bone, joint, tendon, nerve, blood vessel, and you take care of problems that involve all those different systems. And that kind of ties into brachial plexus injuries, which are injuries of the nerves that affect the upper extremity. And when you have problems with those nerves, you have problems with sensation or muscle weakness or the ability to even bring your hand to your mouth. So the young babies I see with plexus palsies or injuries often have problems related to an inability to move the arm.
Right, and we're going to get into how that happens at birth. Often that happens at birth, and I know that we're talking about in layman terms, and I think that's more in the older days. Just think about the backpacks, the heaviness, and what can happen in this area. We're going to have some graphics to show you in a little while. But it's fascinating to me because, like I said, I knew very little about this before this program, and I thought, man, there's so many easy ways to have issues with this, and it's nice that we have doctors that understand. I mean, just it's funny, we had a guitar string earlier on the floor because there's a lot of studio production in here, but if you're looking at little strings like this, that's something you have to deal with when you're looking at nerve endings and everything else. So wonderful to have you here. Dr. Latif, my goodness, urology, pediatric urology, that in and of itself is such a discipline, and I'd love to explain that, what all of that encompasses. And I know that tonight we're here because of Spinal Bifida Month, so we'll cover that as well. But if you can explain urology as a pediatrician versus urology as an adult and kind of give our audience an idea of that.
Well, as a pediatric urologist, you deal with a lot of the congenital problems that happen. There's all kinds of variants that can occur in the development of the kidney, the system that transports the urine from the kidney down to the bladder itself, and then the urethra, how you urinate, and there's congenital anatomic problems of the male genitalia, of the female genitalia, and like Dr. Diamond, there's all these little issues that you have to pay attention, and we in fact intermittently consult the plastic surgeons because there are times when you either don't have enough skin or you have some scarring or you need to augment the structure, and so it is a complicated business, and the function of the bladder, and we'll talk more as we get into spina bifida. The bladder is a very interesting, complex structure.
And it's the purification of everything that's in and out of the body. And that's something, too, we just think, oh, it's a bladder. But no, I'm very happy that you're here because we're gonna learn all kinds of things this evening. And what I'd like to do, because we have two disciplines, like I said, that are relatively different from one another, I'd like to kind of start with brachial plexus. And if we could, Gracie, sorry, who's it? Valeria. Valeria's in the back. Gracie's right in front of me, and Gracie's usually the person doing the graphics. And Valeria, if you wouldn't mind queuing up slide number 1 for us. And when we have that up, it might help describe to the audience what we're talking about. When we were talking about Rucksack injury or backpack injury paralysis, we can see that this is the area of the body that we always throw over our shoulder. It could be people that wear very, very heavy purses, etc. But what are we looking at here in relation to what we're going to be speaking about this evening?
So we're looking at a really beautifully drawn medical illustration of the anatomy of the upper thorax. And you can see that the clavicle bone, there's 2 words that say clavicle, has been split and opened, and that's to show that the nerves of the brachial plexus actually run beneath the clavicle. They, like most nerves in the body, arise from the brain. They go through the cervical spine and upper thoracic spine at C5, 6, 7, C8, and T1 to form different things, namely named trunks, and then they form divisions and cords, and there's a lot of names. Frankly speaking, it was the most intimidating day of medical school to do this anatomy, because believe it or not, every single one of those little yellow spaghetti strings, which are beautifully drawn in this, have names and functions. And you can imagine if this wasn't a black and white drawing in a real person, you'd also be looking at the cupula of the lung, which is the lung apex, the subclavian artery and axillary arteries, and carotid artery, and the nerves that control the diaphragm. So it's a tight little area with a lot of important structures and a lot of things, and in real life it looks a lot more, I think, like the spaghetti bowl in El Paso. It's not quite as neat and tidy as that drawing, but I think that's also helpful to show. This drawing shows those yellow nerves entering the muscles.
Right, exactly. When I was doing research on this show, we have another. In fact, Valeria, if you can pull up slide number 2, it is more cartoon-esque, so to speak. When I was doing research, I was trying to find the perfect slides that would explain to people what we're looking at. This might be, it's a lot easier, but I definitely wanted to show slide number 1 to show the complex, like you said, the spaghetti string. And the spaghetti's yellow here too. How appropriate.
So nerves are often depicted as yellow. They're more often white in the body. They're tough to find at times, but let's take an example. The upper right-hand corner that says axillary nerve. That's directed right towards the deltoid muscle. The deltoid muscle is responsible for forward flexion of the shoulder. So if I could show the audience, for this is forward flexion of your shoulder, and for a good deal of abduction of the shoulder. And when there's injury to that nerve, which can happen in adults by means of shoulder dislocations or trauma, or it can happen in young babies with congenital nerve injuries, like an upper trunk brachial plexus injury. And it's very common, therefore, in a little baby with this type of nerve injury to not be able to raise their shoulder, because specifically that axillary nerve, which innervates or powers or gives gasoline to the deltoid, is absent in function.
And Valeria, if we can come back to the docs really quick, because I would love to have Dr. Diamond repeat the motions that you were doing earlier when that graphic was up, because it does make a difference to where and how the nerves are, raising your shoulders up and down from the front or the back. If you can repeat that motion again, if you don't mind.
So again, the deltoid, there's probably a ton of yoga people watching the show, and they know the muscles way better than I'd ever explain, but forward flexion of the shoulder.
Valeria, if you can put the camera back on the doctors, that would be great. There we go.
So, this is forward flexion of the shoulder, and abduction of the shoulder.
Right.
This is internal rotation, when you basically bring your palm or fist into your body, and this is external rotation. And there's a lot of different muscles around that shoulder cuff responsible for those motions, and the nerves that control those muscles all pass through the brachial plexus at some point.
Again, such an intersection, so to speak. I'd like to, right now, before we go to urology, because usually I kind of bounce back and forth. So, and Dr. Latif, he's been great. He says, I've been watching the show for 22 years, so he gets the dance that we do. So our dance is going to be a little bit different tonight for that reason. But I'd like to speak about the birth canal and when this injury happens during birth, and the complications that happen there. And then maybe we'll take it on to, teenagers or just people that have weight issues, and that's how we have the injury. But first, let's talk about the injuries that occur during birth.
Yeah, so these types of injuries are not totally uncommon, meaning they happen about 1 to 2 times per 1,000 births. And that's a national average, which in general is going down, but we don't know the El Paso rate. It's not totally documented. We actually don't know our own region's rates, which is why it's helpful to have built in our building a clinic like ours. But essentially, the birth canal is a tight area. And when there's challenges in birth, oftentimes to save a baby's life, and to save them from worse problems like a brain injury, tools like vacuum or forceps need to be used, and they're very appropriate at the time. And I, by no means, my OB training left me at my 3rd year of medical school, so I have no I have no
Right.
intelligence in that area. But
Right.
but I gave birth to a baby in my 3rd year. It's awesome, and that was it. But but
least
the
you did
point is that these are really life-saving maneuvers. That's my view on it. I wasn't there, but injuries can occur, and typically they'll occur because the shoulder was either stuck in the birth canal, the shoulder was rotated in the birth canal, and we call that shoulder dystocia.
Right.
And at our higher level birth centers, like our county hospital at UMC, each patient will get a shoulder dystocia score for that reason going into labor to see if they're at risk to develop issues.
No matter what the birth.
No matter what.
Okay. Interesting.
So there are things to look for that can sort of clue you in, but the long and short of it is that at some point there is a stretch type injury, meaning
Right.
the arm is pulled, the shoulder's tweaked, the neck is tweaked, and there's such a significant forceful pull or stretch on those nerves. The nerves do one of several things. They either get very injured because they're stretched apart. If they're stretched so much, they can actually pop. And the last type of injury is they're stretched so much that they actually pull from the spinal cord. And that's what we're really talking about when we're classifying the injury, how bad the injury is, and how the young baby's doing as they're coming along in their younger life.
And if they're torn from the spinal cord, I'm just trying to go through in my head, how would you go back in as a surgeon then? Is there a natural healing process if you're able to go in and place the nerves back in that place? Do you have to actually somehow adhere it back to the spinal cord? How do you do that?
So that is the million-dollar question.
Oh my goodness.
That you touched upon the toughest question in my field, and I'm very lucky because I sort of have a whole community of people nationally and throughout the world that we work together. It's called Plexus Nexus. It's literally a national or international group. We talk about cases and what to do. But there's a lot of different treatment methodologies. The first and the easiest being physical therapy. And if babies are connected with the right occupational therapist, they can do fantastic.
Oh wow, okay.
And for certain types of injuries, about 80–90% of young babies can recover fully. That's not the same when you have an injury like what we call a root avulsion, meaning that spinal cord root is pulled from the spinal cord. In that case, we often have to perform what's called nerve grafting or nerve transfer type surgery, where we literally rob Peter to pay Paul. We use
Right.
good functioning nerves to put them into poorly functioning nerves that serve more important purposes, essentially.
And this is where that plastic surgery training comes in handy when we were talking about that at the beginning of the show.
That's right.
Okay.
So as a plastic surgeon, we train in microsurgery, which means surgery of very small vessels or nerves. And we train in tissue handling. And I think Dr. Latif, the same. I mean, pediatric urology, you have to be a masterful tissue handler.
I like that, tissue handler.
You can imagine a young boy's genitalia after birth whom you need to work on for some reason or not. You can hardly even, no force at all in it, things can tear. So
Right, exactly.
this is very fine motion, fine finesse type surgery that's very well thought out before the operation, during the operation. This is not sort of the frantic operating room you see
Not with
on
that
the
spaghetti
television.
bowl that you described,
No,
not at all.
no.
Yeah. What I'd like to do is take things over to Dr. Latif and talk a little bit about spinal bifida, because you did a beautiful transition into the tissue handling, which means that we can do the little back and forth a little bit now, which is great. And I'd love to talk too about, we described birth injuries, and then maybe just other injuries that may occur as people get older. And what I do want to touch base on this evening, again, this is the Paso Children's Hospital, and little ones, when they're born, just the rate of healing and the rate of growth and how it's so goodness, when somebody's between the ages of 1 and 3, how fast that occurs versus if there's an injury with someone who's 12 or 13. It's a lot slower, and then when we're old like this, you know, we've got a whole different thing. So bringing that into the picture as well.
Sure.
Dr. Latif, if we can explain, and if we could pull up graphic number 3, Valeria, that would be great. Because we hear spinal bifida. If it's something that we don't have on our tongues all day, every day, people are like, what exactly is that? So we're going to bring up this graphic, and if you can, to the best of your ability, I know it's not too complex and it doesn't have all the names and words on it, if we can explain what spinal bifida is to the audience, and then talk about the complexities that you have to go into.
Well, spinal bifida is sometimes a calamitous situation. It's unfortunately a problem that occurs very, very early in development, at approximately 18 days of gestation.
Oh my goodness, that early, 18 days of gestation.
The neural tube that forms the spinal cord starts folding from the head gradually all the way down the back to the tail. And any abnormality in that fusion, that's a very delicate process of 2 layers of tissue coming in and folding it just right at the right time. If that doesn't happen, the nerves that are encompassed within there don't form adequately. And what you see in the representation here is a defect. And these defects can vary. This is a single vertebral space that you see right there, but it could be 2, 4, 6 vertebral spaces that are open, and there are times when the nerves literally protrude into the sac, and times when the nerves defects, be it bladder function, motor function, lower extremities, things like that. Each one is different, and you have to evaluate each child individually to know exactly what their injury is, how it's affecting the bladder function. The other thing that happens is that in this defect, since the nerves can come down and relax, you get obstruction at the base of the brain.
Right.
So you get a blockage in the drainage of cerebral fluid from the brain down to the spine, and you get what's called hydrocephalus.
Valeria, if you can bring the camera back to the doctors, that'd be great. So you were talking about when there is fluid here, because you were pointing to your head, and then down to the spine, and repeat that portion of it.
We have what are called ventricles. These are spaces with cerebrospinal fluid. This is secreted, and it has to travel and get reabsorbed. When it can't travel and get reabsorbed, then this gradually swells, pushing the brain against the skull, and you get damage to the skull. So the neurosurgeon, like Dr. Jimenez, who was here some weeks ago, he not only has to repair the injury to the spinal cord, but he also has to evaluate and sometimes place a drain to provide this drainage so that the brain can develop normally.
And I remember when Dr. Jimenez was here, we were talking about the amount of time, and I know it's different with every patient, I respect that completely, but the amount of time once a birth occurs, and they were looking at how to teach parents to look for something that's off. You know, the head just appears a little bit larger than it should be. He was talking about a spongy feeling to the head, etc., so that it doesn't get to a point where, not that there's a point beyond return, sometimes there could be. What is it that you have parents look for if everything appears on the outside to be fine? So you talked a little bit about, when we were looking at the graphic, if it is a protrusion outside of the skin, that's easy to see. And you said sometimes that may not be the case. Is there always a breakage in the skin, or how does that?
So there are all kinds of variations on the theme. So you can have a close skin defect with a palpable defect. So the skin looks normal. The other thing that can happen is you get a development of a fatty tissue. So you get what's called a lipomeningocele.
Okay.
And so this is something, and you get a deformity. The other thing that you look at, which is interesting, is there are abnormalities in the gluteal cleft, the way that what we call that break between the two buttocks. There's abnormalities. It curves to one side,
Right.
or it's blunted. Sometimes that can give you an idea that there's an abnormality.
Gotcha.
The other thing that can happen is that you get a tuft of hair. And so you get this type of abnormality. And
And that would indicate then that something either hasn't been formed correctly or is timing, the formation, timing might be off. Would that
Correctly.
be correct? Okay.
And then there's other times when there really is very difficult to ascertain. So part of my physical exam, every time I examine these little babies, when they have some type of urologic problem, urinary tract infections, you always need to be very careful in your assessment of the lower spine to make sure that you're not missing what's called the spina bifida occulta, which is a hidden spina bifida.
So here's the $1 million question for you. I know we were joking about the $1 million question, right, Dr. Diamond? But Dr. Latif, when the pediatrician, baby's just born, baby's maybe 20 minutes old, and there's this score, and I forgot the name of the score, but the score that every baby gets. When you're looking for something that might be wrong, you were talking about urinary tract, so the fluids not draining or being absorbed correctly. How can you tell if a little tiny itsy bitsy brand new person has an issue urinary wise? So just as a pediatric urologist, what do the parents look for?
Well, there are two things that are very obvious. One is the child that is born and 12 hours have passed and has made no urine. And so you need to know whether it's urine production or obstruction.
Right, okay.
And the other is the child who every time he does any little effort leaks.
Oh, actually the opposite.
And so
okay.
it's the opposite. They tend to leak in the form that they shouldn't.
Right, right.
You and I are sitting here chit-chatting. And we have no qualms about worrying about our bladders.
Right.
It's doing its job. Wired just so, it functions beautifully.
Exactly.
But any fault in that wiring can lead to significant problems.
This is so interesting. I almost want to have separate shows on each one of these because there are so many different issues. You know, we're talking about, I like the spaghetti bowl that happens in both of your practices. But when we're looking at spinal bifida, like you said, the graphic that we have has one, but it could be several. But very important to note too that they could be completely hidden. And palpable, you were talking about the word palpable, which means feeling what's going on.
Absolutely.
And this is where it's so important for moms to come back to the doctors several days later, you know, to adhere to that scheduling of making sure everything is going well with the little one. I'm going to try to transition back now because we were talking about itsy bitsy tiny ones. And so now I'd like to go to Dr. Diamond again and talk about this brachial plexus and maybe not affiliated with a newborn.
Sure.
Like I said, in layman's terms, and I remember looking at that, and I'm thinking, I have a daughter, she's now 24, but she's tiny. And I think that because when she was going through high school, lockers aren't a thing anymore. And she's carrying around a backpack with, 50 million pounds in there. And then she's got her sports bag and this and that and the other. And I keep looking at her like, please don't break today. Please don't break. But injuries that can occur after birth, I think, again, that there's a reason it's named backpack, but what are some of the other injuries that can happen?
So that's got to be a really heavy backpack.
Yeah.
I mean, that's got to be a hardcore
But you look at some of these
backpack.
kids, and they're twigs,
Yeah,
right? And
but
then, oh
they
my
have
gosh.
iPads now. It's going to be fine.
That's true.
So
it's going to be,
gonna be
again, there's
fine.
that calming part of you. It's going to be fine.
So the deal is that when you're an adult and have a plexus injury, you're doing something pretty intense.
Okay.
we're seeing them in people who are going 110 miles an hour on their Ducati, and then they happen to hit a semi-truck.
Dear Lord.
That's the
okay.
level and degree of force you need to have an adult brachial plexus injury. And we see them in very, very what we call high velocity, high energy blunt traumas, which we take care of at our level 1 trauma center. And they happen typically from motorcycles, sometimes from ATVs, sometimes from car crash. There are very, very severe blunt trauma where the arm gets yanked in some fashion. And same thing gets yanked and pulls on those nerves. Those nerves are extraordinarily protected. So in a young baby, it happens in the birth canal. In an adult, it happens with very severe trauma.
Okay.
You asked earlier what makes kids amazing, and they are amazing. I call them little trucks.
They get right. They
I mean,
just keep going and growing
and they
healing and
heal like gangbusters.
Yeah.
They make us as plastic surgeons look great because their scars look better, they heal great, they don't get infections. You deal with adults and they come with a lot of baggage. Some are smokers, some are using other types of substances, some have diabetes. All those things are challenges for every level of nerve but wound healing. So nerve healing, tendon healing, wound healing, etc. So you know how quickly little babies heal things. You know in adults and older people it can be a challenge to get difficult wounds or problems to get healing. So that's kind of the big difference
huge
between
difference,
the
yeah.
two.
And that makes sense to me too. When you're talking about trauma, I don't know how often in a newborn that a bone would actually break. And I'm thinking with trauma, we were looking at that clavicle earlier, that there could be breakage of bones and then also suturing of muscles back
Sure.
together, et cetera, et cetera. I don't know if you have a case study that was really bad that you'd like to talk about.
So there's, fractures during birth are not uncommon. You probably see more fractures than I actually see plexus injuries, nerve injuries. So fractures of humerus or clavicle. And there's other types of nerve injuries that happen peripherally, meaning you break an upper arm bone and you get an isolated nerve injury right at that same level. But we're seeing a lot of different variants of plexus injury, and we're lucky in El Paso now to have a capable operating room and colleagues from anesthesia to neurosurgery to occupational therapy who can handle this problem and really take care of it well.
Thank goodness for you. So I know I'm repeating myself and I shouldn't, but the more I looked into this, the more fascinated I became in the idea of how in the world, you said, the idea of tissue handling. And we're talking the spaghetti bowl. So there's lots of nerves in there, but you're also looking at the pulmonary system, and you're looking at muscles, you're looking at bones. When you said earlier too, you're a specialist in hand surgery, anything that happens to do with the hand, and psychiatry too, because that's how people talk, they communicate, you watch other people, what are their hands doing, you can kind of figure out what's going on. And Dr. Latif, I'm going to come with you as well, because when we're looking at spinal bifida, we were talking about the bladder and urology, but you are also, the idea of nerve endings, the idea of what might be happening with the pulmonary system. As a urologist, what else do you see in the area of spinal bifida that kind of occurs? And I'm trying to marry these two disciplines together, if that makes sense, of all the complexities and the tissue handlers when it comes to this.
Well, in our setting, we luckily don't have to handle the nerves.
Okay.
The nerves that are injured are far away from the bladder. Those are in the spinal cord, and the neurosurgeon has dealt with the initial closure. The other thing that is interesting is that now, Dr. Jimenez, for example, is one of them who is using a special substance as he closes the spinal cord to prevent scarring, because that's one of the big issues.
Right.
For example, in the tiny little babies, as they grow, that spinal cord is going to migrate.
Exactly. And if you could, I'm going to interrupt you only so that we can explain to the audience why scarring is not a bad thing, but why scarring is such a big deal, because when something scars, it becomes hard, and the flexibility is taken away. And so I remember when Dr. Jimenez was talking about this, it helps pliability, if I'm saying that right, which is why scarring, and you were talking about scarring too with plastic surgery, I mean, it's a whole different thing. With little ones, again, that's a lot easier because they're created to become more and more, and their tissues are happening more. But talk about how important the scarring is.
Oh, it is very, very important, especially in the spinal cord, because clearly the newborn, when you close the spinal cord, is going to start stretching immediately. And one of the common problems that we see is called tethered cord, where the nerves get scarred in place, and as the child grows, the nerve is under tension. And so that's why Dr. Jimenez is using this new substance to try to avoid that, to allow the nerves to heal within the sac, which we call the dura. And that allows tissues to slide, and hopefully we will see less of that problem. And in any surgery, when we do reconstruction, we try to borrow tissue to cover, to allow for motion on top and stability underneath. And I'm sure Dr. Diamond does exactly the same thing.
Question, actually.
Is the care of, once you reconstruct this, you can't just leave it there.
Right.
You have to very carefully place a defense from the scarring that's going to occur. So as the motion starts happening, as physical therapy takes on, you have to have that freedom of movement.
And that, you guys are good at transitioning into each other. So when we're looking at, again, I keep thinking plastic surgery, fine, but it really is all about pliability, right? At the end of the day, with the different tissues. And you were talking about hands, and I'm just think of it, hands, feet, anything that's got all that going on. And when you're borrowing from Peter, what is it? You're robbing Peter to give to Paul, vice versa?
That's right.
Where are you? So when we're talking about babies, let's go back to babies, because this is a children's show or pediatric show. When you need to borrow some tissue from somewhere, with babies it's easy because it seems like anything can just regrow. How are you doing that? Where do you usually, what's the most common area that you usually take tissue from? And that might be a question for you as well. Just when you're trying to rebuild something that went wrong.
Sure. So in plastic surgery, we say we really operate in 4 dimensions, 3 physical dimensions and time. And time is extraordinarily important, particularly for anybody, but in kids especially, because growth is such can challenge or can help, depending. Plastic surgery's roots were in taking care of burn injuries, for example. And for a long time, we tried to figure out how to get skin grafts to work. And then people were trying to put skin grafts from other people onto very severely, burned people. And they figured out that you can't do that because there's an immune system. And then Joe Murray, who, I come from his training program, developed immune suppression, and as a plastic surgeon won the Nobel Prize for the first kidney transplantation to bring it back to urology. So plastic surgery has always been interested in movement of tissue, transplantation of tissue, participated in face transplant, penile transplant, hand transplants, etc. So we take where we can. So in a little baby with a nerve injury who I have to borrow nerve from elsewhere,
Right, exactly.
I'll typically take it from the lower leg. There's a nerve present in all people named the sural nerve. It's not a motor nerve, it's a sensory nerve. It runs behind the calf. And it's too bad we don't have pictures because I do it minimally invasively, sometimes with an endoscope. I leave 3 tiny little bandages that look like hearts, but I take about 15, 20 centimeters of nerve. 20 centimeters is about 2 millimeters in diameter.
Wow.
And that nerve leaves the child numb on the outside of the foot, but it doesn't reduce walking. It doesn't, no major function is lost. They're a little numb on the side of the foot, but
where that goes to fix
But where
something
that
else
goes,
is
that's
so
going
important.
to restore a bicep. you know?
Right,
So
exactly.
that's what we talk about. And other common surgeries I do, other common things I do, skin grafts. I just took care of a young burn victim from Afghanistan. As you all know, we have over 10,000 people, and they are our people and they are our patients. And
They are guests.
they-
Somebody had used that word earlier, and I thought that was a great
they're
word to use.
amazing.
Yeah.
And beautiful. And one very young girl had a bad burn injury, and the burn injury was so bad that her elbow was flexed like this.
Oh, gosh.
And in order to extend her elbow, I needed to bring skin from elsewhere. So I did almost like a tummy tuck for a 2-year-old and took all the skin from the bottom of her tummy and hid the scar well beneath her underwear
look at
line.
you, really?
And you put that on her elbow, and she's going like this, and it's like the best, you know, these are like the best days of our life when you give her a lollipop and she reaches out, grabs it, puts it in her mouth.
No kidding.
The big smile. It's like, there's
And
nothing
could
better.
you give an approximate age?
She's
Just so we kind of
2.
have an idea. She's 2, so she's brand new as well. Goodness gracious. Okay, so you were able to do that, and again, that's that pliability portion of it.
So motion is life.
Right, motion is life. And you were talking about too, when you take away, and maybe I'm just picturing this in my head, when you take away motion in your hands and your arms, it really is so much how we communicate.
Oh, yeah.
In every way, shape, or form, especially with little people.
Yeah.
You know, you're talking about sign language before they can even speak. So that's awesome. Dr. Latif, we are probably at like a 15-minute mark, so I want you to kind of in the back of your heads think of some things that we haven't touched base on yet this evening, because again, your specialties are so specific that I don't want to go through the show and miss something, if that makes sense. With Dr. Latif, if we can talk, because you're a pediatric urologist, and we were talking about tissue healing, not included with spinal bifida, but what are some of the congenital issues that babies are born with that you have to deal with completely unrelated to spinal bifida? Because you were talking earlier about if you're talking about a little boy that's born, and there's a lot of structures there, and I know sometimes things aren't formed exactly right to begin with, and they need to be fixed immediately, because if urination doesn't happen as a newborn, then the body basically gets poisoned. I know that's a dramatic way of saying it, but if you can explain some of the things that you've seen and that you've dealt with.
Well, one of the common abnormalities that we see is called a hypospadias. And the hypospadias is when the opening through which the boy urinates is not at the very tip, but is further down on the penis, on the ventral aspect, on the lower aspect. And concomitant with that, we also get penile curvature, which is where a lot of the plastic reconstructive work comes, because you have to straighten the penis, provide local coverage. Thankfully, the penis comes with extra skin.
Exactly.
And
So you know where to harvest
it
from.
allows
That's a great
us,
point. Right.
it gives us some freedom. However, occasionally you have some kids who tend to scar. Unbeknownst, you have no idea, you haven't done surgery before. You do the surgery, you're very careful. Like Dr. Diamond says, tissue handling, you're very careful. You have knowledge of the blood supply of the tissues. You know to preserve all that blood supply. You know not to burn the tissue. You have to use very careful cauterization when you do have tiny little bleeding. And yet, 6 months later, you have this not very elegant scar.
Right.
And then you have to deal with, and we invite the plastic surgeons sometimes to participate, and you try to, as much as possible, borrow local skin, but sometimes we do have transfer from different places. So we have that type of abnormality. And then we have all types of congenital problems in drainage of urine from the kidney to the bladder. There is a child that, for example, recently had this hugely distended tube that came all the way from the kidney down to the bladder. And
From the kidney down to the bladder. Okay.
yes, so the
I'm just
urine
trying to
has
picture what you're saying.
the
Okay.
urine has to be transported from the kidney which is in the higher aspect of your back, and be transported down. So there can be obstruction anywhere along that tube. So we did surgery to correct that obstruction, but
Okay.
in doing that, I had the vague suspicion that there was obstruction higher up as
Right.
well.
That makes sense.
Well, you can't disconnect this tube at the bottom and at the top and expect it to do well. So you do one part, fix that part, leave an indwelling tube to drain the system, and then come back later and correct that second part.
And when you say come back later, you close the surgery, finish that surgery, and then see,
I
or is
usually
that at the
wait
same-
around 6 months.
Okay,
Let things,
gotcha.
that all the vasculature return. You have to, that lower part where you cut, you have to let all those vessels start creeping into the tissues, develop new circulation, so that you know that there's good blood supply when you go to cut the other end.
Our bodies are miracles. I mean,
Yeah.
they really are. Dr. Diamond, and maybe it was today, maybe it was a couple of days ago, but you were talking about kidneys earlier, and you were talking about borrowing tissues. And am I correct in hearing that there was a first pig kidney transplant in a human being? Am I making that up?
I think you
Correct.
have to ask Dr. Latif.
Dr. Latif,
That's
okay,
awesome.
because I think that's so just. I say this because every time we have one of these shows, there's something brand new and hope for the future.
So
Yes.
there, the credit does not go to the pig or the human or the doctor that did the transplant. It goes to the scientist, the geneticist that's been working with that pig
Right.
over a period of time to change the genetic composition of that pig so it is very close to the human. And so what you do is you work very carefully, painstakingly in trying to modify the antigens that are
Exactly.
carried by that tissue so that it can be easily treated and you don't get a
What fascinates me about that, many things, but the reason I thought about that is you were talking about burn victims and burn victims who were trying to accept graft skin from other people.
Sure.
And it just wasn't working because it was another person. And in my head, I thought about this pig transplant. But and
So-
that's where it comes in. I mean, to accept. I just heard a speaker in Las Cruces earlier this week. His name's John O'Malley. He was a burn victim when he was 9, and he was so inspiring, number one, but there were also photographs of him when they were on the table of trying to graft skin and trying to heal and fix, and that was in and of itself such a process. I don't know how old he is, but this was easily, I'd say, 20 plus years ago.
Sure.
When I say that, and as a plastic surgeon, or just in general, when you're taking tissue from one place to put it somewhere else, and you were talking about, so I'm just thinking about the tissue on the back of my arm is very different than the tissue on the front of my arm.
Sure.
And so when we're looking at internal, and scarring is such a big thing too, finding again where to take tissues from, how do you do that? And let's say you have a very complex hand operation that you're doing on a child, so it's itsy bitsy tiny.
Sure.
And I feel like child skin's all, pure and they haven't been wrinkled yet and the freckles aren't around yet. But how do you think about where that comes from? And just, again, I love case studies because it's like, you know what, I had this case that A, B, C, and D that
Sure.
might do with what I'm talking about.
No, it's got to be right. I think you've touched on so many things just in that little bit.
I do that. I get to, yeah,
you know,
maybe just take one of those.
so-
I'm sorry about that.
But from a tissue engineering standpoint, burn has changed tremendously, meaning we are now tissue culturing your skin if you are burned, growing it, and then spray painting it back on you. So there's a tremendous amount of technology in plastic surgery. And then it's this specialty where it's like the least amount is the best, meaning I fix a cleft lip and all you need is a scalpel, a knife, and a toothpick with some methylene blue to mark your marks and make it really good and really awesome. And so it's a cool specialty in that way. But to give you an example, I had a young man he was involved in a rollover vehicle accident. He lost pretty much all the back of his hand, including the tendons, all the way down to the bones and the joints. And like Dr. Latif said, these are staged surgeries.
Right,
We are
right.
thinking about the first step, second step. It's a chess game. We're 50 steps ahead, and I'm thinking not only about what I'm going to do now, but what it's going to look like, and in 15 years, what it's going to look like for him. So. In his case, I transplanted a piece of his outer thigh. The outer thigh has a very conserved, what we call vascular angiosome, meaning one blood vessel provides blood flow to and veins flow from, and transplanted the outer thigh to the back of his hand, reconnected the blood vessels with my microscope.
With your microscope.
Then come back 6 weeks later to do the tendon work, meaning took, again, Peter, which was functional tendons with less impact to give him big bang for the buck, meaning extend his thumb, fingers. He's about 8 months out from everything. I thinned his flap. I did the plastic surgery stuff, made it look right, lasered the skin, lasered the scars, made it look awesome, made him happy.
Yeah.
And he's back like this.
And before that, you're opening your hand like this. Before that, when he came in, would he have been
Like
so
this,
he was not able to do
and
any
missing
of that?
everything.
And missing everything on top. That is amazing. And again, you're looking at taking tendons, and I'm thinking skin grafting, right? But you're taking tendons from one place to another. How many years did you look like you're like 20. You must be like 900 years old.
No.
You have all, my goodness.
No, but we trained a long time.
I bet. I would like to stop here for a minute, and Dr. Latif, if we can go to you, and this is the time of show where I'm not going to ask a question other than what is it that you'd like to talk about? Because we're a little bit less than 10 minutes out. We're about 5 minutes out. There you go. Anything that we haven't talked yet about that you want to throw in there really quick before we wrap up the show? This is one of those, when the show goes fast, it's been interesting.
Being that it's Spinal Bifida month, and that's what we came to talk to, the long-term care of these patients, because once you have a nervous injury, there's this long-term care, and the vast majority of these kids have some type of reservoir problem. The bladder is a reservoir. They either can't empty well or they leak too much.
Right.
And the management, the delicate management of these kids, and the follow-up, because you have to change doses, you have to make sure their volumes are correct. I always tell my patients, I worry about you not now. I'm not worrying about you in 2 years. I am worrying about how you're going to be when you are 44.
Right.
At 44, what kind of bladder are you going to have? The bladder that you're going to require to go to work, have a family, travel.
The things we take for granted.
The things that we sitting here take for granted.
Yeah.
And so the management, many times we have to manage these bladders by paralyzing the bladder, catheterizing them to empty the bladder.
Right.
And every time I tell a mother that they're going to have to put a catheter through their child's urethra into their child, they look at me with square eyes and they say, "You are crazy." And 99% of the time, these mummies become experts.
Yes.
They learn to handle, and they follow.
Right.
And they're our kids.
And they are our kids. And you hit on such a point, too. Again, pediatrics show, once they hit the age, and I always think, okay, when does pediatrics end? 18, 25, depends when they stop growing. But then that really is the body that you're going to have going forward. And the healing, not that we heal beautifully, and again, we are miracles that way, but when we're looking at the kids and how quickly that goes. Same thing with you. Anything that you want to get across before we close up this evening?
I think we didn't touch upon what these injuries can look like. And I think if there's moms and dads out there that notice that, maybe their child isn't moving their hand, maybe not grabbing something, maybe not raising their shoulder right, let your pediatrician know. And we're really trying to reach out to the pediatricians to know that we're here. We're not in Houston or Dallas where kids went before. We're right in their backyard, and the benefit is that these kids need a lot of help and care to get as good as they possibly can to reach their best self and best potential with this type of injury, which, like Dr. Latif said, may not be exactly like everyone, but it can be an Olympic snowboarder or et cetera, meaning they can do great. And if you notice that when you do all those fun reflexes with your baby, you sweep their hand or palm and they don't grab, or one hand's a little weaker, or you notice when they startle, and most babies, when they startle, as you know, it's sort of fun. I don't mean to play fun with the baby's reflexes, but you know, they start, I know, it's
No,
awful.
I'm with you, I'm with you.
But they startle and you notice, you know, maybe one arm is not. Maybe one arm is just going like this and the other's hanging down. So those are the things to kind of take note of. And then the last thing is, as you mentioned, that the body is so beautiful, and you can then imagine every permutation of a difference can happen with the hand. People can have 2 thumbs, 3 thumbs, 2 pinkies, fingers attached, all those things I'm happy to take care of. That is why I'm here.
And toes too. I know that you're a
And
hand
toes.
guy. I respect it. You're a hand guy. But I guess, you know,
We call the, you know, I don't mean to offend every podiatrist in town, but we do call the foot, at least hand surgeons do, the dumb hand.
oh, stop.
That's just,
You know, you're going to get phone calls tomorrow. I might even get, I'm directing you your way, just saying. So I think that we're kind of down to a point where I don't want to ask another question, but I want to give praise to both of you for being here. Again, you've been here for 22 years. Oh, I have to say the audience really quick. Dr. Latif just went to Switzerland and rode his bike from Switzerland all the way up to Amsterdam, not in one swoop, but in 9 days. So congratulations for that. Thank you for coming to El Paso. You've been here a little bit over a year, you said, and to the El Paso Children's Hospital, because the whole idea and the goal of the Children's Hospital was to prevent people from leaving. You hit that spot on earlier. There is so many things going on in El Paso right now medically that really we're going to get to the point where people aren't going to have to leave here for most anything anymore.
That is
That's
true.
right.
When I first got here, my partners would say, "Where are you getting all these patients?" And they
They're
said they
from our
were here
backyard.
all along.
That's right.
I'm sorry, we're closing up, so I have to finish up really quick. I want to say thanks again very much to both Luis and Gina, who have been here to help man the phones. And again, Burrell College of Osteopathic Medicine in New Mexico State University, which is new for us. So I appreciate you guys being here. I'm Catherine Berg, and you've been watching the El Paso Physician. That's the hardest part of the show right there. And I was